Knows Dr. Narendra Rungta. Sir is the immediate past president of Indian Society of Critical Care Medicine. Is the president of Jeevan Rekha Critical and Trauma Hospital, Jaipur, and Association of SARC Critical Care Societies. I welcome Dr. Rungta for the presentation. Please be seated. We are going to start the session. Please be seated.
Thank you very much, Dr. Rajesh Mishra, for giving me this opportunity to be here. And good morning to all of you, ladies and gentlemen. And this is the hospital where I work. This is our ICU. And the topic is assessment of the critically sick patient and communication with the relatives. Though these were two different topics, and both are very, very important topics. Interpolating both of them, putting them together. So I am trying in a very simple presentation that I am able to convey a bit of message to all of you about how important both these issues are. Early identification of problems of the critically sick patient when he arrives in the emergency room or in ICU, and the patient is brought by very anxious relatives, not sure of the fate of their beloved ones, and therefore in the present era, when the expectation from the medical fraternity is very high, the confidence level is going down, the gap is increasing. Therefore, it is very important that the medical team, the ICU team, the emergency team reacts with protocolized background. Easy communication is made to the family and a correct message is conveyed. So what I am going to talk in next 30 minutes is about early identification and intervention in critically sick patient and emergency itself, rapid implementation of principles of primary and secondary surveys, utilize protocols and bundles towards optimum management of these patients as much as possible, as fast as possible, assure emotionally charged and worried relatives of these patients by communication and actions that they are at the right place and in the safe hands of concerned professionals. Why this problem of concern? Why once they have come, they are coming to a hospital? Why there is a crisis? Because our profession has moved from healing to business, from medical institutions to corporate hospitals, from thanks and gratefulness to the sale of house and jewelry by the relatives, from God's desire to industries admire, from noble profession to respected profession, and finally to just another profession. That is where we stand today, and therefore we have to burden more responsibility, we have to be more communicative, we have to be more convincing in our approach, in our communication to the relatives of the patient. And that is what exactly from public hospitals to corporatization. This is the age-old All India Institute of Medical Sciences, and you can see more than 7-star type buildings coming up for the hospitals, not in other countries, but in our own country. Early identification of critically sick patient is very important. Unless we do that, the anxiety of the relatives would increase only. Therefore, we have to prevent further deterioration. Initiate the process of recovery, buy time for evaluation, diagnosis, and put protocols and bundles in place into management of the patient. And that's how the patient's relatives will feel that they are in the right place, in the hands of a safe team. So if I take a case of a 50-year-old patient who's diabetic, alcoholic, smoker, present with severe pain abdomen, deep rapid breathing, hypertension, altered sensorium, desaturation, falling urine output, we must determine fast, is this patient seriously sick? There is no doubt the patient is seriously sick. The patient is in trouble. A patient who was all right 2 days, 3 days back was admitted in a peripheral hospital and nursing home. The doctor was telling them, don't worry, the patient will be fine in a day or two. He suddenly deteriorates, he has to be rushed to Ahmedabad for further treatment. And if we don't tell him the right thing, right message about the sickness of the patient, exact diagnosis within a limited time period, this is going to be a problem. Will only enhance anxiety of these patients. What type of information is needed further to confirm the diagnosis of these patients, further management outlining of these patients? As usual, we would start with the primary survey, achieving what we call that ABC, identify the main physiological problems, initiate rapid response to patient's arrival. This is likely to imbibe a feeling of confidence into minds and heart of the relatives. I am simultaneously trying to put in how can we directly or indirectly convey a right message to the relatives of the patient. The problem of medical nemesis. This is the book. The most explosive, uncompromising, thoroughly researched attack on greatest health hazard we face today. The health hazard we face today is our medical system. If we face medical system as a hazard, look at the public, how public must be reacting to this hazard. Therefore, medical nemesis is becoming very important. The defense and the legislation, the whistleblower and the protection, there is very little leverage left between legal protection and the strength of the whistleblowers that is happening around the country these days. Therefore, you have to be very sure, very specific and definitive in your approach, because you are likely to fall into the waiting crocodiles who will devour the professionals. We will maintain the airway, we will achieve the breathing, certain saturation, we will put the circulation in right place, and in this particular patient, consciousness is also in picture. Therefore, we will try to do everything possible so that the consciousness or sensorium of this patient is restored to as near as normal, or at least we are able to explain to the relatives exactly what is happening to this patient and how far this patient is going to take to recover. This is airway and breathing. We very fast we achieve that. We try to achieve reasonable blood pressure. Evidence of decreased perfusion is seen. Abnormal heart sounds are appreciated. Central and peripheral pulses are seen. Fluid administration is started as fast as possible. This gives us time. Once we have done that, we have procured the airway, we have achieved a saturation, the circulation is in control. Now we have time to talk to the relatives, taking history, doing a physical examination, charting whatever we have seen, document everything what we have seen and we are planning, send investigations, call for investigation, and initial specific treatment of the patient may be started during this period. All the systems are examined, from respiratory to endocrine, hematological system. You look at every system because in critical care, it is very unusual for the patient to have disturbance of one organ. Multi-organ failure is a different thing. But at the same time, any patient who is dragged into the ICU or wheeled into the ICU is unlikely that he would not suffer at least from one or two organ disturbances. There may not be failures as per we say, but the disturbances of many organs may be there in place. So therefore, it is very imperative that we do not leave any organ under speculation. It is here that we start thinking about first discussion with the family. The first discussion after first examination of the patient, then it has to be followed by ongoing discussion, and ultimately when the prognosis is established or the recovery is established or patient is unlikely to recover, then we have to have an ultimate discussion with the patient. Therefore, we can divide our communication with the family into 3 stages: initial discussion or communication, ongoing discussion or communication, and then the ultimate one. Initial expectations of the relatives and communication with them. This is to convey the present condition of the patient, the possible diagnosis, immediate prospects and prognosis of the patient, who is the treating doctor or the team, have they come to the right place, how long the patient may stay in ICU and hospital, and most importantly, as you go to the periphery more and more, even in cities, the question would be asked how much it is going to be costing to the family. Therefore, we have to be very specific, diplomatic, smart, clever, intelligent, communicative, whatever adjectives and terms you may use, we have to be sure while conveying all these facts to the family. In the meanwhile, we are recording vital signs, fluid balances, FiO2, medications, invasive parameters, which are guided, and we do investigation as guided by history and examination. Bedside ultrasound and echo are becoming very, very important these days. Blood gases cannot be ignored. Lactate levels are very important from prognostic point of view. Metabolic acids is one of the most important indicators of critical sickness and outcome of the patient, as lactate level is. So the patient that I was talking of, previous examination on arrival, blood pressure was on the lower side, had tachycardia, tachypnea, febrile, blood sugar is very high, SpO2 is just 77, distended down, war extremities, high leukocytic count 0.9, lactate 5.8, urine ketones very high. Now this gives us a lot of idea that the patient has most probably diabetic ketoacidosis, or what we call in common language, patient is probably presenting with diabetic coma. After 2 hours, the blood pressure is improving, the pulse, the respiration, because the patient has been intubated. Already, the saturation is improving, blood sugar remains stationary or comes down a little bit, distended abdomen remains there. But what is more alarming is there is increase in blood urea nitrogen. ABG has improved, bicarbonates are now detectable, urinary ketones are there. Now, this is very disturbing. This X-ray that you obtain, this takes about 1 hour, 1.5 hours, or maybe 2 hours in some hospitals to come. Bilateral fluffy shadows indicative of acute respiratory distress syndrome. And this one particular finding puts the prognosis of this patient much lower down than what you would have probably expected as the initial diagnosis only of diabetic ketoacidosis or diabetic coma. Now, in the present era, I would not like to lose a patient of diabetic ketoacidosis or diabetic coma. But if diabetic coma is associated with ARDS, then the prognosis or outcome of these patients become quite questionable. Therefore, the initial communication that you have given to the patient that your relative seems to be suffering from diabetic ketoacidosis or coma, and I have not lost a case of diabetic coma or ketoacidosis in last 1 year, the picture totally changes with this one X-ray that you see. And immediately you want to tell something look, you want to frantically call the relatives, see this X-ray is not good, this is appearing to be acute respiratory distress syndrome, and the prognosis of these patients is not good. After 2 to 3 hours, the clear picture is emerging: diabetic, alcoholic, cough, cold, admitted in district level nursing home for pneumonia, complicated, referred, the emerging diagnosis of diabetic ketoacidosis, septic shock, ARDS with multi-organ failure syndrome. Each one of us knows what is prognosis of these patients, how many patients of this combination of diseases, clinical condition are going to come out. Some of them will die despite everything you do. Is this the time to talk to the family again in details? Yes, it is. And therefore, we should apply medical ethics principles, or basic principles of medical ethics, complete information to the patient about the disease, the background, the data, the statistics, and let them have the pleasure of having autonomy. Means the patient and the relatives would decide what treatment they want to have and whether they want to be treated here or take the patient elsewhere. Everything we do is for the patient's benefit, that is beneficence. Non-maleficence is we do nothing which can potentially harm the patient bodily, emotionally, socially, or economically, and do justice. We provide him everything possible, including ventilation. If ventilator is not available and we are probably expecting after 4 hours, 5 hours, our ventilator would be free and we will apply this ventilator. By that time, we buy certain, apply non-invasive ventilation to these patients. No. This patient must be sent where a ventilation facility is available. The communication failure, the blurred communication, which sends waves of confusion, which does not give a clear-cut communication to the patient's relative, is bad than talking nothing. Therefore, this is the way to chaos, confusion, and will further complicate and create a crisis of confidence. Therefore, the communication has to be very clear and non-ambiguous. Then we have more information, more action, refine treatment, assess response to the treatment, provide organ support, determine best site for care, call for advice and assistance, whatever is needed. And this should be shared with, all this information should be shared with, because the patient's prognosis is in jeopardy, the outcome is in jeopardy. Therefore, information should be given to the relatives. If in case they want to have more consultation, more information, they should feel free. Discussion should be clear, non-ambiguous. It should be simple and in local language. Should not project that I am a motor doctor, and instead give an impression of being humble, knowledgeable, in control, and concerned professional. Should be clearly reflected that you are always available for discussion with them. Only one doctor, the captain of the team, or an authorized clinician who is in knowledge of everything which is going on about the patient should talk to the relatives. At the same time, the other members of should not be very tight-lipped. कोई कुछ बोलता ही नहीं है, बताता ही नहीं है. They should not be tight-lipped. Unauthorized information, however, should be avoided, should be broad, sincere, and nearly correct. You cannot be correct 100%, but it should be as correct as possible. This will give a lot of confidence to the family in spite of being in a very, very critical condition. Avoid trying to be absolutely correct. It should be supported by the current data and previous literature. It is recommended that doctor avoids discussing the financial matter, which should be left for counseling team to do. As a rule, it's important not to convey any message which might infer that the treating team members are not unanimous in the management strategy of the patient. Avoid finding faults with members of the treating team, duty doctors and nurses. Nurse ने ये कर दिया, मैंने तो ये कहा था. Thus, absolutely should not be allowed on complaints from relatives. However, it is important to investigate diplomatically such reporting and then rectify. But you should not turn a deaf ear to such complaints. You should not them imbibe in your mind and diplomatically look if any such thing has happened and try to rectify them. This will prevent relatives from thinking that there have been blunders in management of this patient and further chaos and problems for all of us. The discussion between relatives and doctors should be duly recorded and documented. There is no value of discussion which has not been recorded or documented. If death is imminent, everything possible